Welcome, everybody. I imagine some more folks are going to trickle in here to this all virtual Department of Medicine Grand Rounds. Welcome. We're very lucky today to have a visiting professor from Mayo giving a talk. First, I'm going to introduce Dr. Ratonia Carr, who is the Cyrus E. Rubin Chair and the Division Head of Gastroenterology at the University of Washington, and she'll be introducing our speaker today. I'll pass it off.
Thanks so much, Hannah. Thanks everyone for being here. It is my pleasure to welcome our guest speaker, Dr. Amy Oxentenko. I will tell you a little bit about her in just a moment. We're celebrating the founding of our division through this lectureship. Dr. Wade Bollweiler founded our division in 1949 and was incidentally an expert in malabsorption, as is Dr. Oxentenko. So thank you all for being here. Dr. Oxentenko is a distinguished gastroenterologist, educator, and leader at the Mayo Clinic. She currently serves as Vice Dean of Practice and Chief Patient Experience Officer. She previously served as Chair of Medicine at Mayo Clinic, Arizona, and has held numerous educational leadership roles, including program director for both the GI Fellowship and Internal Medicine residency programs, as well as associate chair for education in the Department of Medicine. Dr. Oxentenko is a nationally recognized leader, I will say actually internationally recognized leader, who has been deeply involved with our GI societies, including the American College of Gastroenterology. She's been on their board of trustees and executive team and is the immediate past president of that society. She's also contributed to a number of leadership and training initiatives through the ACGME and World Gastroenterology organizations. She's an accomplished educator and scholar. She's co-directed the Mayo GI Board Review course, which I think we've all taken at some point, and served in major editorial and content leadership roles, including MACP and the American Journal of Gastroenterology. She is very well published, and most of us know her either formally or informally through her ability to mentor people near and far. Her contributions have also been widely recognized with numerous honors, including the Mayo Clinic Distinguished Educator Award, Program Director of the Year Award, and ACP Laureate Award. And she was Heliogastro's Woman Disruptor of the Year as well. Dr. Oxentenko is known for her authenticity and is widely respected for her ability to elevate those around her while advancing excellence in patient care, education, and physician leadership. We welcome you today. She'll be talking about top 10 things every clinician should know about celiac disease in 2026. Thank you.
Perfect. Thank you, Dr. Carr, for that kind introduction. Thank you all for having me today. It's an honor to be here to celebrate, like Dr. Carr mentioned, the recognition and of the GI division's leadership, and to be coming here named in that regard. So really appreciate that. Excited to share some of these tips and tricks of managing patients with celiac disease, and hopefully, regardless of what your specialty and what you're going back to in terms of clinic or hospital later today, I'm hoping there's at least a few little pearls of wisdom you can take from this talk going forward. So I have nothing to disclose. And Dr. Carr, thumbs up that you can hear me okay, and you can see the slides advancing. Okay, perfect. So this is really what I hope that everybody walks away with at the end of this. First of all, I want to make sure that you recognize the evolving way that celiac disease is presenting to our clinical practice today. Also, I want to just make sure people have a good understanding of the diagnostic testing that's available for patients with celiac disease and how we manage these folks. And then finally, what do we need to know in terms of managing that patient with celiac disease who has, lack of improvement of symptoms or who has recurrence of symptoms? I'm going to start with a case that I think is a patient I've actually had in my office, a 24-year-old woman who comes in with worsening of her irritable bowel syndrome that's diarrhea predominant. She carries a known diagnosis of iron deficiency anemia, and she's been on thyroid replacement for a number of years, but her control has been very erratic with that replacement, and she's required escalating doses of levothyroxine. So all of those things should be a little bit of a clue that, gosh, something might be going on with this patient in terms of the combination of symptoms and diseases that she has. So she's newly married. She would love to conceive soon. And her clinician that she sees is astute enough to put 2 and 2 together with diarrhea, iron deficiency, autoimmune thyroid disease and orders an IgA tissue transglutaminase antibody and finds that it's markedly elevated, 100 with normal being less than 4 for that lab. So just some cases and questions that the patient asks. She wonders if she needs an EGD to confirm the diagnosis. She wonders about how, the management may impact her, especially if she wants to conceive. And she wants to know how this may impact her ability to not only get pregnant, but safety in pregnancy. So we'll address all of those things. So I think hopefully all of you will find this topic relevant because celiac disease is fairly common. And when you think about 1% of the US population has celiac disease, that's pretty common. So you think of the last 100 patients that you've seen in your clinical practice, if there has not been one of those that has a diagnosis of celiac disease, it shows that we're probably underdiagnosing it. And part of that may be a lack of recognition of some of the non-classical features, which in today's day and age is more likely how these patients are going to present to us. I know, there's regions of the country, and I would say the West Coast is probably pretty common, where we have a lot of patients who are either on a gluten-free diet or have been labeled with celiac disease who may not have met the criteria. And so again, I think this is important. We are asking people to change everything about their lifestyle in terms of analyzing everything they put in their mouth. So I like to think we should be as confident as we can about this diagnosis before we label someone with this. We're not going to go into the pathogenesis in detail, but I think it's just really important to know that this disease has a very well delineated pathogenesis, and we know that each of the steps of that pathway really manifests in some way that we see these patients clinically. So again, I've highlighted those key facts, right? Someone who's at risk, meaning they have genetic susceptibility because they have the presence of a permissive haplotype, has to be taking in gluten. With that, it produces an antigenic stimuli, which damages the bowel. And through that, it produces autoantibodies, which we're able to measure on serum. So again, we'll come back to all of these levels, but it is one of these that's very well understood. It means that there are great markers for therapy, but that has also been a limiting factor in terms of where we are today. So like I mentioned, there's a few things that we know must be true for someone to come and present with features of celiac disease. Like one, they have to be genetically susceptible. Again, they have to carry HLA-DQ2 or DQ8 haplotype, and they have to be consuming gluten, even in small amounts of it. But we know there are a lot of other factors that we don't have a great handle on. It's that big third sphere of environmental or additional genetic factors, because we realize some people may present in infancy. We know that others may present at age 80, and why that vast variation in timing of presentation, in the severity of presentation, is somewhat unknown. We know there's lots of variability in terms of when we first take in gluten in our diet, how much we take in. We're learning more and more about the role of antibiotics, microbiome, things that affect our gut permeability that all likely increase our risk to some degree of celiac disease. Like I mentioned, we think about approximately a 1% prevalence in the US, and you can see when you look across the world, if you take worldwide serology, about 1.4% of the world's population has positive serology for celiac disease, a little bit less than that, 0.7% by biopsy. And it's not a surprise, I would say, to most people that we see more celiac disease where there's, better socioeconomic support for healthcare, more proximity to healthcare, access for diagnostic testing, and negatively correlated with paucity of healthcare resources and those of minority backgrounds. So we know there's a lot of global variation. I think the one thing that's interesting in having presented internationally, there's parts of our world that see very little celiac disease, because in those parts of the world, wheat may not be a staple cereal, and so they just may have low levels of it. But what we're starting to see is this trend where areas of the world that had low prevalence of celiac disease are starting to see an emergence of it, because they are starting to adopt some of the westernized diets that we have, the growth of convenience and fast foods that are gluten heavy. So again, I think with the tail that we see now of patterns will change over time for sure. I think that we also know, and again, I don't have a great explanation for this other than maybe the comfort foods and things that we eat may be different and depending on the latitude that we live in. But if you look, we're all in good company between where we are today in Seattle and, where I reside in Minnesota. You can see the more northern latitudes you live in, the higher the likelihood and odds ratio of developing celiac disease. And we know that several meta-analyses have borne out these same results. And again, lots of hypotheses into why that may be, but I think it's just something to note, and probably why we see in certain Northern European countries higher likelihood of celiac disease as well, in addition to genetic factors. So we're going to get into all of these things in detail. We're going to talk about the clinical ways that patients may present. We'll talk about the supportive serology that we have. We'll talk about the biopsy findings. And obviously, we want all of these patients to improve both clinically and histologically once we put them on a diet. But it's really important that both the serology and the biopsies are very dependent in terms of their sensitivity on someone taking in gluten before you do that testing. So just remember that. And remember that when you're testing a patient for celiac disease who has already gone gluten-free, even for a matter of weeks or months, it will decrease the sensitivity of both of those parts of testing, which could lead to a falsely negative diagnosis. So the first thing is, what are the various ways that celiac disease may manifest either in adults and in kids? And we know that there's not only these differences by age that I'll mention, but based on data that was presented about a year ago at DDW, there's also differences by race and ethnicity as well. But you can see for adults, diarrhea is probably still the single most common GI manifestation that this will present with. But if you look, that other very big piece of the pie called other is all of these things, these extra intestinal features, such as abnormal liver biochemistries, infertility, headaches, peripheral neuropathy, chronic fatigue, other laboratory or vitamin and mineral deficiencies that make up a pretty large component. Other things that you see there, iron deficiency, anemia, metabolic bone disease screening. You can see in children, it's very different. Usually that's for them, it's going to be growth abnormalities where they fall off the growth chart, abdominal pain, and then family screening because they may have a parent or sibling with celiac disease. But I want to call out that comment on the bottom that's really, really important, is just being aware that about a third or more of patients with celiac disease have an elevated BMI in the overweight or obese category. So just realize that, just because someone is overweight does not mean that they don't have celiac disease. It's very possible. The other thing to call out is that about 10 to 15% of patients with celiac disease may have constipation as their predominant bowel pattern. So even if someone comes in with constipation, don't rule out celiac disease because of that bowel pattern. Why they have constipation, unknown, but we know a lot of those patients have pelvic floor dysfunction in relation. So I think for all of you, this is probably, if I had to, have one slide, not to commit to memory, this is the sort of thing that's great if you have an office space, tack this up or have this at the ready access to think about who we should be screening for celiac disease. Mass screening for all of the population, despite this being a common entity, is not endorsed. But again, many of the things on this slide are not uncommon. So again, just calling out a few of them. Our guidelines would say everyone with irritable bowel syndrome with either a diarrhea or mixed predominant pattern should be screened for celiac disease. Things like microscopic colitis that are very common in this population, IgA deficiency, first-degree relatives. So again, just being aware of these and having a low threshold, especially if they have other concurrent autoimmune disorders, is really important. I'm going to just mention a few of these in more detail. Iron deficiency anemia is definitely worth calling out because this is the most common extraintestinal feature that these patients will present. It makes sense. Iron is largely absorbed in the duodenum, which is where this disease largely affects the small bowel. So we did a previous study looking at if we took all comers that were going to endoscopy with an indication of iron deficiency anemia, that if they had any GI symptoms that could be compatible with celiac disease, up to 15% of those, a diagnosis of celiac disease was made. But you can see even in the absence of any GI symptoms, almost, close to 10% of patients were diagnosed. So iron deficiency anemia, you really need to think about evaluating those patients for celiac disease, even if there's some other obvious potential source of blood loss. And I mention that because I would say, women from age 18 to their mid 40s are probably the most overlooked in terms of celiac disease because they're menstruating. Yet that's where autoimmune disease tends to occur most frequently. So just make sure you don't overlook it in those women. And so requesting that we get biopsies in those folks and anyone who's undergoing an upper endoscopy is absolutely critical. I think the other thing that's important to remember is these patients are at high risk of metabolic bone disease, and this is a leading cause of morbidity for these patients, high fracture risk. And again, it makes sense. They're not absorbing calcium and vitamin D to the same degree, which leads to osteopenia, osteoporosis, osteomalacia. So again, a low threshold if you have a premenopausal patient who has metabolic bone disease to screen them for celiac disease. And then finally, this is always for, internal medicine trainees, kind of a common popular board sort of question is about recognizing the other manifestations of celiac disease, such as the skin manifestation. So dermatitis or DH represents an intestinal sensitivity to gluten. This is not people rubbing their elbows on a table that has flour or gluten contamination. This is because of the gut reaction to gluten, just like a patient with celiac disease. This rash is very, very itchy. So patients will complain about itchiness, often on the elbows, buttocks, other extensive surfaces. The skin biopsy findings are pretty pathognomonic when you do immunofluorescence. And most of these patients do not have GI symptoms. And so they can be falsely reassured that a topical cream that might help get rid of their or an oral medication that helps heal the skin is the treatment, but they really need to be on a gluten-free diet to help with the origin of this issue. So practical suggestion number one, remember that celiac disease has both, classic and non-classic features, but I would have a very low threshold to screen for it, given how prevalent this disease is and how common it's presenting with non-classical features today. Next thing is how should we screen for celiac disease using serology? So these are typically on the left there. You can see the serology that have either in the past or currently are available to you. I would say the top one, the traditional anti-gliadin antibodies, are typically not available clinically anymore. You can see they have very low sensitivity and specificity. They have been replaced by the one on the bottom, the deaminated gliadin peptide, which you can at least see the IgG-based version is very high, but that's sensitivity and specificity that are high in patients who are IgA deficient. So the guidelines would say if you're going to screen someone for celiac disease, the only thing that you need to check is the IgA-based TTG in combination with an immunoglobulin IgA level. So you can see with that being said, very high sensitivity and specificity. People might say, well, why would I not just also check the IgG-based serology at the same time if I don't know their IgA status? And it's because the IgG-based serology do not have good sensitivity for the most part in patients who are not IgA deficient. So only do the IgA TTG with an IgA level. We also know that the higher that level is, the greater the likelihood of celiac disease. And I'll show you some data on that in a little bit. One thing I just want to really have you be cautious about, because I see this being done a lot in practice, is people who order like an entire panel. And I know there are some institutions that only have panel testing as your only option, which is unfortunate because it's not cost effective or clinically effective to do so. Obviously, people might think, well, more is better, right? If I order more of them, am I more likely to find celiac disease? And you could say, yes, it increases the sensitivity, but you're more likely to have decreased specificity, which translates to a false positive. And I would say the deaminated gliadin peptides can give you false positive tests in someone if you're ordering panel testing, and it's not necessary to do so. So just to also level set, why do we check that IgA level? Well, we want to make sure that IgA-based serology can be trusted because, again, patients with celiac do have a higher likelihood of being selective IgA deficiency, probably 3 to 5% of those patients. So when you check that immunoglobulin IgA level, if it's at the normal level or even high, that's fine. You can trust that IgA TTG results. You do not need to order any IgG-based testing for that patient. However, if that IgA level is below normal limits, then you really need to go on to check their other immunoglobulin levels, IgG, and probably others like IgM, IgE, because you want to make sure that you can rely, first of all, on an IgG-based serology if their IgG level is normal in that setting, but just making sure they don't have a number of these immunoglobulin levels that are low because patients with CVID can present very similarly or concurrently with patients with celiac disease. So if their IgA is low, but their IgG is normal, then you can use IgG-based serologies, but that's the only time that you should use those. So suggestion number 2, IgA-based TTG is the serologic test of choice when you're screening for patients with celiac disease. But again, make sure they're consuming a gluten-containing diet before you put them through that testing. And I would say we'll talk about it in a minute, but probably should be on a gluten-containing diet about 8 weeks before you test. So the next question is, should we biopsy all patients in the evaluation for celiac disease? So again, based on adult guidelines anyway, any adult with a positive serology should undergo small bowel biopsies. But remember, these serologies are not 100% perfect. 95% plus is pretty darn good, but there are going to be a small percentage of patients who may be negative serologically. So if they have very strong features, even if they're serologically negative, they ought to undergo small bowel biopsies. So you could, say, well, why do we need to do that? Let's say their serology is very high. Well, first of all, it allows us to confirm the diagnosis because maybe, and especially more so in kids, sometimes we can see elevated TTG for other reasons. Sometimes we can see that in the setting of liver disease, other autoimmune disease. And it gives us that baseline histology before we introduce a gluten-free diet so that when we do a follow-up biopsy several years down the line, we can at least see that we have made progress in terms of the healing phase. And again, when you look at where celiac disease affects the small bowel, over 95% of the time it's going to be in the proximal duodenum within reach of a standard endoscope. So again, we're able to confirm the diagnosis in that regard. NASP, again, which is the part of the guidelines for pediatrics and nutrition, have supported that you can do a biopsy, non-biopsy approach for kids. It makes sense. Parents aren't eager to sedate their children with anesthesia if it's not necessary. So there are very strict criteria for children to make a diagnosis of celiac disease without the need for a biopsy, but they have to tick all of those boxes, be symptomatic, have very elevated TTGs, have permissive haplotyping, have this, remain positive on a second blood draw at a certain interval apart. So it is possible. I think for adults, it could be used very selectively. So I've seen patients who are in the middle of a pregnancy who understandably don't want to take the risk of sedation, even though we can safely sedate pregnant patients if we need to. But I don't know that it's worth that risk. Or if someone has significant, pulmonary or other issues that they feel like it's unsafe to scope, you could do a non-biopsy approach. But in that case, you'd want to make sure the serologies were very suggestive. So you can see in the two graphs on the right, if you have a TTG that's 10 times upper limit of normal, the likelihood of them having MARSH3, which means total villus atrophy, is quite high. And you can see on the bottom, for those folks who have a TTG greater than 10 times upper limit of normal, their positive predictive value for celiac disease is about 99%. So there's very few things in medicine that give that high of positive predictive value. So again, you can feel fairly confident in that case, but I would still argue for most adults, we should get a biopsy. I think we've always been taught there's some of these just classic sort of endoscopic findings that may be described in someone with celiac disease. They'll have a loss of fold, scalloping, et cetera, but you can see the sensitivity of those things are really, really poor. The specificity, however, for an enteropathy is really high, meaning if you see one of those things, loss of fold, scalloping, almost certainly if you biopsy that person's small bowel, you're going to find something abnormal. It may not always be celiac disease, although that's most commonly where you're going to find, but it shows that we can't wait till we see positive findings in the bowel before we biopsy these folks. Now, for all of you who are non-gastroenterologists, you may wonder why this slide is even relevant for you in terms of the number of biopsies that we should be taking. And this may be because you might be, the people caring for these patients with celiac disease. Not all of these patients necessarily need to be referred to GI unless the diagnostic, question is in play or they're having ongoing symptoms. But what's really important is if you've seen a patient who's been told they don't have celiac disease based on past biopsies, it's really important to go back and look how many biopsies from the small bowel did they have. I would say historically in the past, we used to say 4 was enough, but you can look going from 4 biopsies up to 6 biopsies almost doubles the yield in terms of patients with celiac disease. So 6 is really now deemed the minimum standard for the number of biopsies. So if someone was ruled out in the past, but you look and they only had, let's say, 2 duodenal biopsies, that would probably be inadequate and that patient should be retested with current day standards of numbers of biopsy pieces taken. So suggestion number 3, biopsies 6 or more are recommended in the diagnostic workup of all patients who have suspected celiac disease, even in the absence of classic endoscopic findings, which, like I said, are often not present. The next question is, are histologic findings specific to celiac disease? So here's the whole list of various things that you may see, right? I'll go to the bottom first. Intraepithelial lymphocytes should absolutely be there in any case of a patient with celiac disease before they've gone on a diet. That is the minimum histologic finding. But in addition, you will typically see partial or total villus atrophy, crypt hyperplasia, and then chronic inflammation. And you can see in these 3 visuals, the top one would be a very normal looking small bowel, long finger-like projections. The middle slide there is partial villus atrophy, where you can see those villi length are about decreased by half. The crypts below them are increased. And then that bottom slide where the villi are completely absent. And all you see are these tubular crypts here that go deep into the bowel and lots of inflammation in the lamina propria. So again, one clinical conundrum that I think faces all of us, whether in primary care or GI, is when you get a report back from a small bowel biopsy and it says there's no evidence of villus atrophy, but the only thing they see are intraepithelial lymphocytes, which occur based on our study here in about 11% of patients. That was 15 years ago, and we were seeing a pretty steep increase in the percentage of patients with that histologic finding. The important thing to remember is very few of those patients had celiac disease, less than 10%. Most of them have some other cause of why they have that histologic finding. So you can see what those are on the left, things that are very common, right? People taking NSAIDs can have that finding of intraepithelial lymphocytes and have preserved villi, H. pylori infection, maybe even some transient foodborne illness or viral gastroenteritis can cause enough inflammation that causes those findings. What's a little bit of a shorter list, and we talked about this within the GI division this morning, are those things that cause villus atrophy. Again, that's a shorter list. Things like medications. I would say olmesartan is one all the internists should be aware of. That's an angiotensin receptor blocker that has a black box warning that it can cause a celiac-like enteropathy. The other drugs to think about would be things like mycophenolate mofetil, checkpoint inhibitors, and CAR T therapy is starting to see an evolution of enteropathy. But then don't, like I already mentioned, combined variable immunodeficiency can be seen, autoimmune, and then some of the more rare things. I mentioned the olmesartan-induced enteropathy because, again, I see a lot of, internists will still be prescribing this medication, but just to be aware of this medication causing this bowel impact. Other ARBs are less likely to do this compared to olmesartan, so there's something unique about its structure. But what's really important is to look at that time range on the drug. People who were in these case reviews and systematic reviews, as short as 2 weeks up to 13 years. So this is not one of those cases where you start the drug and they have symptoms immediately after. You can see that the mean or median time to being on the drug before symptom manifestation is 3 years. So just really do a careful review. If you have a patient that's on that medication, if they're having GI symptoms, weight loss, features of malabsorption, that certainly could be a culprit, and I would switch them off. If you diagnose this, you take them off the olmesartan, the bowel heals, symptoms resolve pretty quickly. So practical suggestion number 4, while histology can be quite suggestive of celiac disease, it's not specific, especially that finding of increased intraepithelial lymphocytes alone without villus atrophy. Other differentials need to be considered, particularly if they have normal celiac serology. The next thing is, what is the role, and I would say probably the limitations of HLA testing in the workup for celiac disease. So again, if you look at this kind of diagram on the right, you think of the very small population of celiac disease patients. All of those patients have to have one of the permissive haplotypings, HLA DQ2 or DQ8, DQ2 being the more common of those. The challenging thing is 30 to 40% of the normal population carries one of those permissive haplotypes. And so what that means is it's necessary to have that in order to be at risk of celiac disease, but by itself is not sufficient. Otherwise, 30 to 40% of us would have celiac disease, which is not the case. How this test can be very helpful is it has a negative predictive value of nearly 100%, which again, very few things in medicine have that strong of a negative predictive value, meaning if you have a patient who thinks they have celiac disease and their HLA is negative for DQ2 or DQ8, you can tell them quite confidently that they don't have celiac disease with few exceptions. So how I will use HLA testing in my practice is I don't do this on all patients by any means. I will reserve this for those patients who either have, discrepancy in their serology versus histology. So let's say they have enteropathy findings on biopsy, but they're serologically negative. That's when I would check it. Or let's say, probably less helpful, they have mildly positive serology and a normal histology. Again, it may be helpful in that case, but, again, 30 to 40% of the population will have a positive test. Important to remember. And we'll talk in a minute about, I will use this test for someone who's already on a gluten-free diet, and now they want to think about undergoing a gluten challenge. You can use this to decide if that's necessary or not. So suggestion number 5, HLA testing can be quite useful in the evaluation of celiac disease if the patient is already, if they're DQ2 or DQ8 negative. And like I said, we'll talk about the role, especially once they've already been on a gluten-free diet next. So again, I don't know how common this is here. I know, in the West Coast, there's probably a much higher prevalence of people who are on a gluten-free diet, either because, they feel like they feel better on it. Maybe they have gluten sensitivity or all of these sorts of things. And you can see based on Google Trends, the West Coast has a pretty high hit rate of people Googling a gluten-free diet. So again, if this is someone who comes to you and they would like to know if they have celiac disease, but they've never been tested or maybe not been accurately tested for celiac disease, the first thing that you can do if they're already on a gluten-free diet is start with that HLA testing that I just mentioned. Let's say they do not carry either HLA DQ2 or DQ8, so they have non-permissive haplotypes. You can stop the testing and you can tell them quite confidently they don't have celiac disease. Perhaps they have non-celiac gluten sensitivity, and whether they choose to continue a gluten-free diet or not is completely up to them. It will not harm them if they consume gluten, other than it may make them feel unwell. But let's say they do carry one of those permissive haplotyping. Again, they might have celiac disease, but they may be in the 30-40% of the population that also carries that. So then it's an open discussion of how willing are they to undergo a gluten challenge to answer that question. Some patients may absolutely not be open to a challenge. They may say it makes them feel too unwell, and that's fine. I don't think we should strong arm our patients into that. I think it's an informed decision that can be made. But if I have patients who are interested or considering a gluten challenge, what I will tell them is they have to take in very little gluten per day during the challenge. This is equivalent of a few crackers a day, a piece of bread a day. This is not eating hordes of gluten with every meal during that gluten time. So again, that's really important to quantify how much they need to take in, because that will help with tolerability. I also tell them that even though the guidelines say you can do a challenge for as short as 2 weeks, ideally, you should try to get them to 8 weeks, because you will be able to rely on those results more confidently than if they only did the challenge for 2 weeks. I also tell all of these patients, if you're halfway along the challenge and you just don't feel like you can go on for the full 8 weeks, just send me a message before you quit. Maybe we just take a day or two rest from the gluten challenge and then we restart at a lower dose. But if I can support them in getting them to 8 weeks and then do serology and biopsies at the end, then I can feel more confident in results in terms of counseling them for the future. So suggestion number 6, in patients requiring an evaluation for celiac disease who have already been placed on a gluten-free diet, and maybe they didn't have the appropriate testing or any testing done before, that's where haplotyping with HLA really could be useful, looking into the presence of HLA DQ2 or DQ8 before embarking on a challenge. Remember, if they don't carry these, you don't need to do a gluten challenge, and you can tell them they don't have celiac disease. If they're positive, again, then that's a different conversation with informed decision-making. All right, so how do you manage celiac disease once you have made a diagnosis based on all the things you've just learned? Well, still true in 2026 is that the treatment of choice, and in fact, the only treatment of choice, is a lifelong gluten-free diet, wheat, barley, rye. Really important, though, because I don't think any of us, unless you have a background in dietetics and nutrition, probably most of us could not adequately counsel or even come remotely close to counseling a patient on what that means. I also think it's really substandard of care to have them just go to the intranet to find out what a gluten-free diet is, because there are so many nuances with label reading, cross-contamination. I find that patients who only go to the internet and never have the benefit of a dietitian often become actually overly restrictive, and sometimes become imbalanced in the nutrition because they think gluten-free equates to a healthy, balanced diet, which it doesn't always equate to. So any way that we can get patients access to a skilled dietitian who understands a gluten-free diet, I think it's really incumbent on us to try to connect them with that. We should also consider assessing these patients' nutritional markers. Probably the most important ones would be iron, vitamin D. I often check B12 as well, because of so many areas of the bowel that B12 has manifestations of deficiency and absorption. I will also think about checking their thyroid status, given the concurrent and high likelihood of autoimmune thyroid disease in this population. And I will typically check their liver biochemistries, both transaminases and cholestatic profile as well, given the association. And again, maybe that's coming from the eyes of a gastroenterologist, that I want to be proactive about addressing those GI and liver relations. And I'll talk about those in a minute. Important that in adult patients, we think about evaluating their bone health. Like I mentioned earlier, this is a leading cause of morbidity, like I mentioned. So bone density is recommended on all adult patients when they're newly diagnosed. And then advising them that first degree relatives should be screened. So again, that's parents, assuming they're, still alive or not old enough, 80s or beyond, that probably it's maybe less relevant. But siblings for sure. And then children, depending on their age and with the input of their pediatrician, would be important. I would say sisters of patients with celiac disease are probably the highest risk. But again, it's just an important discussion to have with them. If they have first degree relatives who are blatantly symptomatic with features of celiac disease, they should not stop with just serologic testing. Those patients ought to undergo small ball biopsies as well. And then we'll talk about the follow-up in a minute, but this is probably where we have the most opportunity in these patients. It's not enough to make the diagnosis, put them on a diet. We have to make sure that we follow them up to make sure they have not only healing in the future, but making sure they're supported no differently than a patient with inflammatory bowel disease. So I bring that up because, look at how this diagnosis impacts these patients. And again, it goes back to that first slide of making sure that we feel as confident as we can in the population. You look in that upper left, this is the quality of life impact of celiac disease, which I have the red box around, compared to other major health issues. So you can see it has as much of a negative impact on quality of life as things like IBS, diabetes mellitus, heart failure, overall chronic health conditions, which oftentimes we don't think about. But again, knowing this impacts every single meal of theirs, you can see why that would be the case. The bottom left, you can see the satisfaction of patients with a gluten-free diet in patients with celiac disease, which you can see it split down the middle, and about half of patients have poor to very poor satisfaction. And then you can see on the right how many patients with celiac disease would rather have a medication than a diet as the treatment of choice, which again, I find very fascinating. And this is just something that just piques my interest, to be honest, when we take patients with, let's say, Crohn's disease versus celiac disease. So take those with inflammatory bowel disease, right? Every day there's some new therapeutic on the market that we can offer those patients, which is great. They have lots of drug options. But many of those patients come to our clinics and say, gosh, is there a dietary treatment that I can be put on instead rather than a drug therapy? On the other hand, I see patients with celiac disease every day who I'm giving them a drug therapy. And the first thing they say is, isn't there a medication I can take instead? So it shows that neither group is right or wrong. It shows that patients want options. And we should ideally love to give our patients options. They see food as medicine. And I think that's something that we should continue to take advantage of, when there is a dietary therapy, we should make sure that we maximize that, but we should not fail in our pursuit of drug therapies for those who want that also. There are probably some things that we can do at various stages of life to reduce the risk, particularly, let's say this patient that I presented to you, if she decides to have children, what could she do to minimize her children's risk of celiac disease? Well, there's been a lot of literature on when infants are going to be starting gluten ingestion. It's kind of the Goldilocks thing, too early is not great, too late is not great. There's like this perfect sweet spot of timing of gluten ingestion in infancy that probably is most helpful for those at increased risk. Also, a slowly escalating amount of gluten ingestion rather than a bolus of it is more important. Perhaps, and this is a little bit harder to measure, when some child has, an enteric infection, which are obviously incredibly common in childhood, could we reduce gluten consumption during those periods of time when their gut might be a little bit leaky? What can we do to prevent gut infections, including consideration of vaccinations with things like rotavirus? And then again, regardless of etiology of why they may need it, just being very judicious with antibiotic use, of course, the lifespan, just to preserve our microbiome. I showed the pathogenesis on the left earlier, and I think what's so unique about celiac disease, like other things, is because we know the pathogenesis, it has been, lots of areas of target for pharmacologic therapies. Many of these are in all different phases of clinical trials, but we have things that can either genetically, get the mouse here, genetically modify the gluten that we take in. There's also glutenases that can break down gluten to make it less antigenic. There are things that have been are being studied to work on tight junction modulations to make those tighter so that antigens can't come through the bowel. There are things that look at how we can block, the binding of TTG to gliadin particles. I think as we think about CAR T and all of the things we have learned with the immune system and tolerance, this is probably where we are going to see the most advances, I would think, in terms of patients who could perhaps really eat and enjoy a normal diet is when we think about biologic therapies that may be targeted to things like anti-IL-15, anti-OX40, which are centered at the immune part of celiac disease. People may remember a few years ago, there was a vaccine that was going through clinical trials, but that was taken off the market because it failed to show a level of improvement that would be expected. So this is really tough, and patients have asked me, why have we not made more progress in terms of therapies for them? I think it's multifactorial. I think the first thing is we have a treatment that we know works, right? We know a gluten-free diet works and it heals these patients' bowel. It makes them feel better, even though, like you said, or like I showed you, patients may not be satisfied that that's the only treatment that we have, and understandable frustration. I think probably the bigger elephant in the room is that gluten avoidance does not cost the healthcare industry or insurance companies anything. It costs the patient something. We know their diet can cost upward of twice as much as a gluten-containing diet. And so I think because of that, what sort of interest is there in putting money into investing in drug therapy when there is already a treatment of choice? I think the other thing down in the left lower quadrant is that, let's say whatever medication may go through and be authorized for use, we have to think about, especially as we think about biologics and things that target the immune system, what are the potential side effects of that therapy weighed against the side effects of a gluten-free diet, which again, if counseled appropriately and it's a balanced diet, has very little to low risk compared to a medication, which certainly may have some. And then when you look at the studies that are all going through clinical designs, how they are all put together is those patients typically need to be put on a gluten-free diet, show intestinal healing, then be exposed to both gluten and whatever study drug to see if it is really effective in preventing recurrence of enteropathy. So most of these studies and trials are designed where patients already have to learn the gluten-free diet, and many of them become then savvy enough that they feel like, I understand this diet now. Maybe it's not worth me subjecting myself to a medication that is unproven. So those are some of the challenges. So I think, practical suggestion number 7, all patients with celiac disease should be on a strict lifelong gluten-free diet, avoiding the things that I mentioned. And dietary referral is really essential, I think, and appreciating and normalizing to your patient, even if you don't have celiac disease, that you understand the challenge of that diet for them, I think is really important. So once you have made that diagnosis and you get them on a gluten-free diet and they've seen a dietitian, you've done all of that baseline testing, which is on the top of that slide. Well, typically what we do is we recommend those patients have a check-in at about 3 to 6 months, see how they're doing clinically. If they had symptoms, you should recheck serology at that point. You should see either a normalization at that point or a significant decrease in their serology. And if there were other vitamin, minerals, or other labs that were abnormal, that would be an opportune time to recheck that. Then you can see once someone has normalized their TTG, we recommend that be checked annually just to make sure it maintains a normal status. And you can see that typically we will rebiopsy someone at 2 years after their diagnosis was made. In the past, we used to recommend, and old guidelines would say that would be done in a year, but we found that many patients, especially if they were older at the time of diagnosis, required 2 years for healing. And some patients, even at 2 years, may still have some mild intraepithelial lymphocytes or other subtle findings. If and only if they had an abnormal bone density at the time of the diagnosis, would you repeat it at that same time in 2 years? If they had normal bone density at the time of diagnosis, you would not need to repeat that. So suggestion number 8, adult patients with newly diagnosed celiac disease should have plans for both serologic and histologic follow-up. Okay, number 9, what's the approach to patients with non-responsiveness? So what that means these are patients with celiac disease who you put on a gluten-free diet, they don't clinically improve from the very get-go, or they improve initially, but they have secondary non-responsiveness, meaning they later redevelop the same symptoms. So you can see this is not uncommon. Over 15% of patients with celiac disease will have non-responsive celiac disease. And you can see all of the pieces of the pie here. That biggest piece by far and away is gluten ingestion. Sometimes patients just may disregard the recommendations you give, but probably more often it's just that they have gluten getting in their diet in some way that they're not aware of. But then you look across these other things. Some of these are not uncommon, right? They can have concurrent irritable bowel syndrome. They may have bacterial overgrowth. They may have an eating disorder. Very commonly, they may have lactose malabsorption because of where lactase lives on the small bowel microvilli. And then microscopic colitis. So really important to know that patients with celiac disease have a 70-fold increased risk of microscopic colitis compared to the general population. So they certainly could have more than one thing contributing to ongoing symptoms. So these are the folks that I really will do a little bit deeper dive in terms of cross-contamination or compliance, and again, in a very non-accusatory sort of way. But you can imagine the older you are at the time of your diagnosis. So if you're in your 50s, 60s, 70s, which again, we see those patients, probably going to be harder to convince those patients unless they have pretty significant symptoms to change their diet that they've been used to for so many years. I would say the really challenging years are the teenage years, college years, where they have, different sources of where they're getting their food, and they just don't want to be deemed different than their peers around them. The other group are those folks that, are executives, or they travel a lot. They're not in control of their diet. They go to a lot of social functions where they don't control what's being served. So that's another group that has a high likelihood of getting gluten cross-contamination or having issues with compliance. Those who are asymptomatic, or similarly, those who were detected through family screening. So again, I ask in a very non-judgmental sort of way on a scale from 0 to 100, how often is anything that's getting into, how often are you sure that things are gluten-free getting into your mouth? And so again, that just helps me in terms of targeting anything less than 100% gives me an opportunity to figure out how I can get them to be most successful with the diet. So this is, a really busy graph, but I'll just say, if you look at the left, you have that patient with non-responsive celiac disease. That left column is just asking yourself, how certain are you that the original diagnosis was correct? If the diagnosis was not made at your institution, then going back to find out if they can find the original serology, the original biopsy slides that you could have reviewed here, checking their HLA if that's relevant. Did they ever respond to the gluten-free diet? And if not, maybe looking for one of those other things, especially if they're serologically negative, that might be more likely to be true. Let's say that original diagnosis was correct. You have good support for it. Then the next question is, given that big piece of that pie was gluten contamination, particularly if their serology is still elevated, which can be supportive of that, careful dietary review, maybe sending them back to the dietitian to re-review because it's so overwhelming at that first visit. I also recommend at that phase, if they have not had improvement, to have a pharmacist consider reviewing their medications as well as over-the-counter supplements. So we know that some formulations, even of levothyroxine, contains gluten, which again is really surprising given those two conditions can coexist. And then let's say you've done that, gluten has definitely been eliminated. That's when you go to this column of the left of those things that make up those other pieces of the pie. Again, just be really cautious. This is not a checklist that you do everything in that upper right box. This is where you use clinical judgment. So again, probably this is where you take in clinical considerations. If someone has a lot of gas and they clearly think they have a lactose issue, well, that's pretty easy. You don't even need to do a breath test, right? But for patients who it's not as clear, probably the highest yield might be rebiopsying their small bowel, make sure they don't have refractory celiac disease if it's been at least a year. And then considering colonic biopsies, given that association with microscopic colitis that I mentioned. So suggestion 9, in these patients with non-responsiveness, the original diagnosis should be clarified. You really should assess gluten ingestion. And then if that's not apparent, I would say the highest yield, unless there's something very clinically targeted in one pathway, would be to repeat the small bowel biopsies and colonic biopsies. And then finally, we talked about non-responsive celiac disease, which is different than refractory celiac disease. So refractory celiac disease is what patients will Google once you've made the diagnosis of celiac disease, and this is what they all dread. So this is where they have a persistent enteropathy, plus or minus symptoms, despite them following a gluten-free diet for a year. And so there's two types. Type 1 has, no clonality to the lymphocytes, fairly easier to manage, and has a better prognosis compared to historically those who have type 2, where they have monoclonal expansion of the lymphocytes, higher likelihood of developing a T cell or enteropathy associated lymphoma. Again, this is where your pathologist can be very helpful, looking at stainings of CD3, CD8, immunophenotyping, all of those sorts of things to help guide this. So I shared this yesterday as well. This was just a very small study that kind of, I would say, revolutionized how we manage patients with refractory celiac disease. So budesonide, which I'm sure you use for a lot of other purposes, including, let's say, microscopic colitis, but this was done in a study of less than 60 patients, most whom had type 1 refractory celiac disease, but about a fourth of them had type 2. Again, that's the one that has the poor prognosis. So these patients were given budesonide in what we call open capsule formulation. And you can see that over 90% had a clinical response and about 90% had a histologic response. And even in those who had the refractory type 2 with the monoclonality, half of them lost that clonality in follow-up. So this really became more standard of care for refractory celiac disease. We put them on open capsule budesonide for a prolonged period, then taper off. And some people may need low levels of this medication or an immune modulating agent if it's not to get them off steroids if applicable. So suggestion number 10, ongoing villus atrophy really should prompt an evaluation for refractory celiac disease after a year of being gluten-free if present. And if refractory celiac disease is found to be present, oral budesonide can be useful for both histologic and clinical remission in both type 1 and type 2 refractory celiac disease. So this case I presented to you, this was a patient that decided to undergo an EGD. She wasn't pregnant at this point, although I've had patients equally who have been pregnant who have presented in the same exact way. And in those cases, we've pushed off the EGD until after they deliver. And again, knowing how long it takes for the bowel to heal may still show classic findings. What's really important in these patients, like in this case, you start them on a gluten-free diet, the serology normalizes, symptoms improve, that's all great. We pat ourselves on the back. But just remember, as their small bowel heals, any medication that they're on is now going to be better absorbed. So let's say in the case of levothyroxine, as they start to absorb that better, you may need to dose adjust their levothyroxine. You may need to, again, knowing that she had required escalating doses before diagnosis, now this patient may need decreasing doses because they're absorbing better. Other medications will be viewed in that same way. I think this is also those questions she's going to ask is when I have a child, when do I introduce gluten? How much? Those are going to be important discussions in combination with her pediatrician. And then I think what we've learned a lot as well, which I think we probably underestimated, you think about a patient that you may see with Crohn's disease. It has always been the adage that we tell those patients, get your disease under control and in remission before you get pregnant, ideally, if you're able to do that. Well, we know now that that's the same as in patients with celiac disease. If we can diagnose this and get them on a gluten-free diet before pregnancy, it will reduce their preeclampsia risk. It will reduce low birth weight for their babies and will decrease preterm birth risk. So again, same sort of benefits with any chronic inflammatory condition. If we can get that under better control before pregnancy, everybody has a better outcome. So take-home points here, really important to have a broad awareness of all of the ways that celiac disease can manifest. You may be seeing one in a hospital or clinic patient very near and in the future. Remember that IgA-TTG along with an IgA level is the recommended screening while consuming gluten. And again, avoid panel testing because it's really not deemed to be appropriate. And while a diagnosis can be made with serology and biopsy, again, there are select patients that you could consider a non-biopsy approach, but I would say that should be the exception rather than the norm and have a good reason of why you might avoid a biopsy. And just remember, I think there's a lot of promise for these patients, and what patients want more than anything is hope, right? They want hope and they want options. And so I think we should give them hope, telling them there are a lot of pharmacologic targets that are coming through various trials, yet in current day, gluten-free diet really still remains the only effective treatment. And maybe those things will allow them to be less scrutinizing of their diet, but I suspect they will all often be, at least early on, in combination still with a gluten-free diet. So I want to thank you for your time and attention. And I will turn it over to Dr. Carr. I don't know if we have time for questions. And
Yes.
I'll see if I can stop sharing.
Thank you so much, Amy. That was really great, very comprehensive, and I hope useful for everyone watching. We have no excuse now to miss these cases. Hannah, are you doing the questions?
Yeah, I am. So we have one question in the chat asking if you can elaborate on screening in folks who are iron deficient. Specifically, are you saying that all patients should be screened regardless of GI symptoms if they are iron deficient?
I think they should. I think yes. Now you could say if you have a patient with, chronic melena, they have chronic kidney disease, have AVMs in their small bowel, they have chronic melena, they have some other like overt form of blood loss. I mean, you could screen them, but obviously there's something so blatant in that regard and it may not be applicable. But I would say yes, for all comers, if you have someone with iron deficiency, they should be serologically screened. And probably in that patient, because they're iron deficient, they're going to be scoped as well, right? I mean, if you don't know why they're iron deficient, they're probably going to get a colonoscopy depending on age and symptoms. And if they're going to have an upper endoscopy, again, you should biopsy their small bowel if the indication for that EGD is iron deficiency. Even in that study we did, we found a large proportion of patients who had celiac disease and iron deficiency. They may have had erosions and some other finding on their upper endoscopy that would have been maybe in some way someone would have said, oh, they have erosions. That's maybe why they're low on iron, and not bother to get small bowel biopsies. But we found that the yield was still very high in getting small bowel biopsies. So I think, again, as a GI doc, if we were to scope someone from above with that being the indication and small bowel biopsies were not requested, we should obtain small bowel biopsies regardless of other findings that we see.
And that's even regardless of heavy menstruation as well.
Right. And that's what's tricky because that's, like I said, the group that often that's what's blamed on.
Yeah.
Now, I will, in that case, what I will typically do, because it could be both, right? I will check their serology. If their serology is negative, then before I put them through a biopsy, probably what I would do next is say, let's send you to either primary care or a gynecologist to see how we can get better control of your menstrual periods, whether it's through OCPs or an IUD or something like that. And then despite that, if they are persistently iron deficient, despite controlling of their menses, then I might say, gosh, should we do an upper endoscopy of small bowel biopsies, even if you're serologically negative, given we don't have a good control of why you're persistently iron deficient despite the menorrhagia being controlled.
That makes sense. We have another question in the chat asking about bile acid malabsorption and how common is that in non-responsive celiac disease, and then how would you treat that?
Yeah, that's a great question. We know that bile acid malabsorption is super common in patients with, let's say, irritable bowel syndrome who have diarrhea. So given all of these things can overlap, there's no doubt that someone who has non-responsive celiac disease could also have bile acid malabsorption. And that probably is contained in that piece of the pie that has IBS. Some of those will have bile acid malabsorption. So there are tests you can do to test for bile acid malabsorption with, 48-hour stool tests and whatnot, or spot tests with a bile acid malabsorption panel. But to be honest, that's one of those things where I feel like you can put someone on a bile acid binder for a trial of 2 to 4 weeks. And I feel like in patients who have bile acid malabsorption, that works fairly magically. And in fact, oftentimes they become constipated, and then that's largely playing a role. So I think that is something that probably should be added, and it's probably incorporated in the IBS piece of the pie, but absolutely could be playing a role for sure.
I think we have time for one more question. And in the chat, we have a question about commenting on how expensive it can be for a gluten-free diet, and that acknowledging that Italy provides some monthly stipends to people with celiac disease to help sort of offset these costs. And curious if there are any instances of either insurance reimbursement or financial assistance programs that you know of.
Yeah, I mean, that's an amazing question, because when you think about it, given that is the treatment for a chronic condition, the cost difference between a general diet and a gluten-free diet really should be a healthcare cost, right? Mm-hmm. And so I think that's not ubiquitous by any means. In fact, that would be a rarity for any sort of company to cover that, I would say. And so if people know of that, that's would be a helpful thing to float around. I think the encouraging thing, given that has not been uniformly true, is when you look historically, the cost of the gluten-free diet has gone down by probably 50% compared to what it was in the past. So it is less expensive now than it was even 5-10 years ago. I think the other thing that has been helpful is there are so many more gluten-free food options than there were 10 and 20 years ago, partly because people, whether they have celiac disease or not, are seeking out gluten-free food. So that has been a very hot part of the food market with much more availability. And I think that has driven the cost of these foods down. So I suspect maybe even 5-10 years in the future, I suspect we may not see any difference or very little difference in the food cost, maybe other than the things that require, maybe some of the breads and things like that require a little bit different of processing. But that's a barrier. And that, again, this is another reason why the healthcare industry, I think, has not necessarily been favorable about pharmacologic targets, because right now that cost is just being absorbed on the patient level.
Absolutely. We are a little bit over time, so folks, feel free to log off. I do have a question though that I would love
Yeah,
if you
of
have time to
course,
answer.
of course.
I'm wondering, how common do you hear folks complaining of heartburn with gluten consumption?
That's a good question. I would say I would say not. I mean, if it's like classic heartburn, then I'd say, well, do they have concurrent GERD, reflux disease? I'd say the hard thing is celiac symptoms can be so non-specific. So I might have patients that only have nausea, right? And we know nausea may be a manifestation of reflux. It could be a manifestation of like 20 different things, right? And so I ask a patient if they have, like, if they say I have heartburn, like, explain to me what that heartburn is, right? Because if it is true heartburn, like a burning sensation rising up in the chest and whatnot, I will probably be more likely to manage that patient as maybe an acid, reflux sort of thing first, maybe do a PPI trial in them and whatnot before I think about screening them for celiac disease. If they describe that heartburn as actually just kind of a gnawing, burning kind of epigastric discomfort, well, that could be reflux, but that could be celiac disease. It could be dyspepsia. It could be it could be one of a lot of things. So I think honing in and trying to get a little more detail about those symptoms would help you decide. But again, like I said, screening people for celiac disease, again, there's so many instances where it would be appropriate. So I think the important thing is, if you're at all thinking about it, it probably doesn't hurt to screen for it, right? Because we're probably under screening.
Yeah, absolutely.
Thank you so much.
Perfect.
Appreciate you being here, Dr. Oxentenko, and thank you all for attending.
Yes, thank you. Have a great day.